Hey, Dr. Kimberly, it says we're live up in that corner over there.
Hey, come on, everybody! It's time.
Oh,
It's
time.
time.
Let's do it. Yeah.
Rolling on the road
With the doc,
rolling on the road
with Dave,
rolling on the road.
with the doc.
100 shades of diversibility with guest host Captain Darcy.
Oh, let's go. Let's go.
Well, Pastor Daryl G is rolling on the road right now. So I think I'm really loving that rolling on the road. We're going to say thank you so much for tuning in. And yep, look at there. We got a viewer already tuning in from
Hey,
Atlanta,
Pat.
Georgia. And that is the young lady who is doing our theme music. Woo.
Nice.
But we want to say thank you so much for tuning in. And on this special day, I did get some, I don't want to say pushback because it was a good thing. They said, oh my God, you're actually doing another day. Oh my God, we cannot wait. So guys, don't think that we're ranking this. Yeah, people were excited about doing this extra day here. So I think I'm a little excited about this as well. But we have Dr. Eric Walchik. Everybody put your hands together. Yay.
Woo.
And
Hello, Internet.
he's and he is a member of the University of Health West Michigan team along with Trinity Health. And as you can see, it's scrolling down there at the bottom. And we're just excited to have you today. Thank you.
Oh, it's my privilege. Thank you.
And what does Pat say, Dave? I can't see
You're
that.
so welcome. I know this show is going to be good. All right. So, expectations, Dr. Walchuk. So,
Well, we'll try to meet him.
all right.
We're open.
Awesome.
We're open to all. We're going to answer all the questions and really get into it, I think.
Well, we kind of had some marching orders from the senior publicist to really talk about the broken heart syndrome, and that's kind of what our flyer talked about. I had a heart attack back in May, and actually tomorrow is my time to go to finally see the well, I've seen the cardiologist because you start out with like every 2 weeks, and then it goes from 2 weeks to once a month, and then once a month to once every other month, and then they do your big echocardiogram. It gets read, and then they look at it and they say, okay, this is what you can do now. But for me, my marching orders were, we know who you are, we know what you do, we need you to slow down.
No, don't say it. No, no way.
And Dr. Walchek came in there. He's just so he has his papers. Yeah, even drew pictures. I said, what is this? So I'm going to give it to you. The floor is open to you to talk about what you will.
Oh yeah. Okay.
No, well,
Well, the broken heart syndrome. How about a little bit about that? It's a rare condition, right? So maybe about 1% of people who show up in the emergency department with chest pain could have it. It's much more common to see in the intensive care unit. Actually, perhaps up to 20% of people in there will have it. And no one knows for sure, but they think that the mechanism is that you get a very stressful event and that you have an adrenaline surge in your body of an overload. And those chemicals hit the heart all of a sudden, and the heart can't tolerate it. And so it gets very stunned, gets lack of blood flow into the deep tissues, and gets very weak all of a sudden. And so patients will present with chest pain, they'll present with shortness of breath, they'll present with congestive heart failure, they'll present with arrhythmias. So they can look like just about any type of heart condition when they come in. So you got to kind of figure it out after a few steps. And then the heart gets dilated or stretched out, usually at the tip. If you think of the heart like a football, it's like at the end of the football. That part won't squeeze, but the middle and the other part will squeeze more. It'll be like hyper squeezing, really hard to make up for it. And that shape looks like a Japanese octopus trap. That's where it got its name, Takotsubo. We call it apical ballooning syndrome or broken heart syndrome now over in the US. Because often you'll see a situation where someone will have a tragic event occur in front of them. They get some horrible news, or maybe just the stress of having a surgery. And those are really kind of the common things we'll see people kind of talk about that happened right before.
Well, when you listed all of the symptoms, I didn't have any of those at all.
And your symptoms were?
I just had nausea and vomiting. That was it.
And that could have been partially due to the flow of blood is not going forward as well because it's not pumping forward, and so it backs up a little bit, and you'll see it congest in the abdomen cavity and kind of see some upset stomach type symptoms.
We want to say good afternoon to Electa Queen, Yantia. Electa Queen is here in Grand Rapids. Yantia Atkinson is down in Atlanta, and we have Dee Coates, who is in Detroit, Michigan. I would ask that all of you ladies please go over to Rolling on the Road or 100 Shades of Diversability on Facebook so that I can get your comments up, because right now you're on my personal page. So if you can please go over to 100 Shades or over to Rolling on the Road, which is on Facebook, or even go over to YouTube and it's 100 Shades, and then we can throw your comments up here. All right, because you guys are definitely commenting and I can't get them all. But you said only 1% of the people have this happen to them. So what about, moms and dads that lose their children tragically, with gun violence? It doesn't happen to them?
It certainly could. And we don't understand exactly is why it happens to some people and not others. Probably like a lot of things in cardiology, there's probably some genes that underlie this adaptation. When you get hit with this event, whether or not you can tolerate it and manage it well or not is probably a little bit of you have a tendency towards having it or not. There's some people have said that the tip of the heart has more of those receptors for adrenaline. And so some people might be more prone to it, have more of those receptors, and so they get hit harder with it. Yep. So
as Pat's just saying that our sound went out and it froze, and then David D says hello from the big D. But I don't even know enough to be dangerous. But I learned over the past number of years, just because of friends dealing with cardiologists, that the heart has plumbing issues and electric issues.
Yeah.
That's
how we talk about it.
Yeah. So which one is this?
So this is actually, if you think of it as a house, right? You have plumbing, electrical. This is the walls of the house. So this is the pumping of the house.
So this is even a third issue.
Yeah, and then the valves of the doors. That's how I always talk about it. So,
wow.
So this is actually a diagnosis. It's a cath negative diagnosis, meaning when we take people to the cath lab and do pictures of their arteries for blockages, like you would normally see for like a heart attack or a blockage in there to try to fix it with a stent or open heart. Typically, these patients won't have severe blockages. It's more related to just the muscle not working well. Okay. And that's why you can see kind of some different presentations. And then the other thing we should probably also say, especially with our audience today, women tend to have different symptoms than men for all the heart stuff. And it can be just the way we're raised or maybe the way we're wired. No one really knows that. But women will have maybe more for like the classic heart attack, pain between their shoulder blades, pain in their left shoulder or neck, maybe just really short of breath and sweaty, maybe not have any chest discomfort. And so it's often less recognized unless someone in the family, has had it and tells the story. Like you said, they have a friend who went to a cardiology visit and heard kind of the symptoms, and then they're more aware. That's why we're always happy to do these, to get the word out so people know if they get a weird symptom, it's not normal, they should go in and get checked.
I think
I've had
it's
some
just
other
really
weird
knowing your
ones
body.
too.
So
What's that?
there was a wonderful article. Let's see if I can pull that up. Let's see. We go to share screen, right?
Mm-hmm.
You're at this better than I am. Click share screen, and then we go here, and we click share. Did it show up? I can't see.
There it is. Yep.
There we
There
go.
you are a second
There
time.
you are, yeah.
Let's see. Can we scroll down and get the? Let me go here. How do I do that? Get the title. The title of it. There it is. Now let's see if that shows up better. Yeah, there we go.
hmm
It says Navy veteran overcomes broken heart syndrome with expert care at U of M West. We want to say thank you so much to Chris for this article and to U of M Health West as well as Trinity Health. We say thank you, thank you, thank you. Now, in there, you talk about there are two types of heart attacks and that I had them simultaneously.
Well, we divide them up, and it's for the person, but doesn't make a big difference for them. Probably, right? They didn't feel good. Maybe their EKG is abnormal, and their blood tests are abnormal for heart damage. When the heart cells die, they release this protein in the blood that you can do a blood test for, and that's how we kind of know something's wrong. And it's very, very sensitive to any kind of irritation of the heart, high fevers, car accidents, heart attacks for real, pneumonia. You can see these blood tests go up a little bit. So we always have to figure out why they're going up. And if you go in and find an acute angry artery with a 90% blockage and you put a stent in there, that's more the classic heart attack. They call that type 1. And then if you have some one of the other things that happen, more of a strain on the heart, then we kind of categorize it as type 2. Their outcomes are a little different. Sometimes the medicines you use and the recovery things you do are a little bit different depending on what the situation is. And typically the broken heart's more of a type 2.
So in the article, you said that it happened simultaneously. So how does it happen simultaneously?
Part of it is, they don't really know, but sometimes with all of that adrenaline, one of the things that does is constrict all your blood vessels to keep all your blood to the center of your body. I imagine you're getting attacked by a wolf or something. You don't you need to fight and run and can not bleed to death. And so it probably causes some spasm of the vessels and decreased blood flow there. There's some other kind of fancy technical things that can happen with the heart pumping, but most of the time you don't really know until you do the heart cath, and then you can say, oh, okay, the arteries aren't too bad, or they might have blockage because they're the right age with risk factors, but it wasn't the cause of their whole problem. And then you can put them into this other category and kind of go after the apical ballooning syndrome. And often it gets better by itself within a few days to weeks. But it doesn't always get better. It kind of depends on how bad or intense the damage and strain was on the heart right at the beginning.
Okay, we want to say hello to Vertaji, who's watching from Detroit. We want to say hello to Monique Reddick, who's watching. And we say thank you so much for tuning into Rolling on the Road with Dr. Kimberly and Dave.
And Dee's comment is, a wolf. She goes, I know Michigan has wild dogs, but wolves. We do have wolves in the Upper Peninsula. That's a whole different episode that we're not going to cover today about the wolves in the Upper Peninsula.
Yeah.
Yeah.
Lion, whatever you want.
Yeah, exactly. So, I mean, just so we can.
The article.
Oh, yep. Pat said the article is very well written. And thank you to U of M Health West for getting that out there. So what prevention, whatever, ounce of cure or something like that. What are those? What do the kids say today? But that, so what, when should somebody go into the ER?
for most of us, we always were kind of primarily talking about heart attack. And so a new onset of symptoms, chest pressure, aching, tightness, squeezing, heavy, super tight bra, baby pain goes down the arm or up the jaw into the back. You're just short of breath for no reason, sweaty, nauseated. You can have any constellation of that stuff, but you shouldn't normally do that. And that's not how you normally feel. And it's happening. You can wait a few minutes, but if it's not going away, you should definitely call an ambulance and go in and get checked. We want there to be a false alarm because most people don't show up. On average, they show up with their heart attack about 3 hours into it. And if we can get you in the first hour,
that's
open
the
up the artery,
average.
that's the average in the country.
So how long? How long does a heart attack last?
You can have symptoms that last 12 hours, 24 hours. Just kind of depends. But after 12 hours, pretty much the damage is done. Even if we open the artery, it's not going to probably have much improvement. That area is going to be dead, and the heart doesn't heal that back. Like it can't regenerate like other organs. So if we get you in the first hour, it's kind of the golden hour. And if we get the artery open, you can have full recovery of your heart function and really have no debility afterwards. But the average is about 3. Most people are like, it's going to go away. Maybe it's heartburn. They'll try some antacids, and maybe I'm getting sick or the flu. Especially if you have not really typical symptoms. Like you just feel nauseated. Why would you think you need to run in? We all get upset stomachs from now and again. Right. So it's hard. It's difficult because some people just don't recognize it until it's really bad, and then the body usually finally they're like, okay, something's not right, and then they come in.
And the damage is done. She said the golden hour. Wow. So again, it's that first hour, huh?
It's the same thing for stroke too. I mean, if they can get in there early, faster you are. We have a phrase that we say, time is muscle, and you don't get it back.
Wow, up to 12 hours of having symptoms.
Yeah, because sometimes it's kind of opening and closing. Your body's trying to clear the way on its own. You'll have kind of symptoms that are waxing and waning, or coming and going. And so we'll still, fire alarm. Everyone's running around. Get them from the ER to the cath lab about up to 12 hours. And then after that, you still take them, but we're kind of like, it's probably they waited too long,
What if the hospital is backed up when you get in there and they can't get you within the first 24 hours, 12 to 24 hours?
Well, that's the important thing about having the right kind of system in place is that if you come into the triage in ER and you say, I'm having chest pain, the national guideline is you have an EKG done in 10 minutes and read by a physician in 10 minutes. And when that ER doc sees that EKG, they activate the on-call, if it's the night or weekends, or the team that's in the hospital. And then our goal is that we have the artery open in less than 90 minutes. So it's a like I said, bells and whistles. Everybody's go now, because time's muscle. And unfortunately for some people, their first symptom is an arrhythmia and they drop dead. And that's why we have AEDs everywhere now, because if you can get them out of the bad rhythm, then you have time to deal with the heart attack. And, I've done this long enough now that we have seen people, if we can, 15 more minutes, we could have saved them, so we definitely have the system, I say, greased. As soon as you hit the ER, we're trying to do it as fast as we can to get the artery open. And that's like the classic heart attack again.
We got a question. Dave, want to read the question?
Yeah. That if someone has chest pains often, could you detect a past heart attack since the symptoms last so long?
There's different ways. Yeah, the blood tests for heart attack go up over 12 to 24 hours, but they stay up for about a week and then kind of dwindle off again as your body kind of clears them. Sometimes you can see it on an EKG. It usually takes kind of a lot to change your EKG. An echo or ultrasound of the heart, which is pretty commonly done. You can sometimes see that an area is not moving anymore and scarred like an old heart attack. And then kind of like the ultimate way to look at that is a cardiac MRI, but those are harder to get and less available in many towns.
Because the machines don't exist, or just hard to get to that?
Partially, yeah. They're expensive, and there's a wait time to get them, and so they're getting done more and more commonly, and there's more and more people being trained to read them in the country. So they will be more commonly done for sure. I mean, in Grand Rapids, we have, several hospitals have them, so we can get them done. But like if you live in, the Upper Peninsula, like we're talking about, it's harder to, have access to that kind of test. But an echo and an EKG and the simple things often can detect it by themselves.
Okay. Dee asked, do we still take a baby aspirin if you don't
That's
have
a great
any?
one.
And
That's a great one.
Should I get them and keep them handy?
I would say if you are the right ages, right? Men over 55, women over 65, and you've got the risk factors, blood pressure, cholesterol, smoking, family history, having some aspirin around is not a bad idea. But we don't say like we used to, just take an aspirin a day starting at 55 or 60 for prevention. Because they did a few studies in the last few years showing that the aspirin, can cause an ulcer in the stomach, and you can have major bleeding problems just taking an aspirin a day. And that sort of washes out any benefit of reduction of heart attack. So we kind of are a little more selective now. And if we see that there's some plaque on a CAT scan or calcium in the arteries, or you've had an event, then we say, yeah, you're kind of in a higher risk group. You should take an aspirin every day for prevention. But the normal adult walking around, even elderly adult, if they're healthy, we don't tell them to do it as primary all the time anymore.
Do we have a question?
Yeah, Pat asked, is there something special that somebody should say to make them check that if you're having a heart attack?
Yeah, like if you're going in the ER,
Yeah.
chest pain is the magic words. Or I think I might be having a heart attack. I mean, hopefully they will take that seriously if someone says that.
Okay.
And I think you need to be, like we were talking before about disparities and all the things that, we kind of understand that happen in the world. You should be confident and say, I think there is something wrong. I need help, kind of a thing. And sometimes you got to put it in their face a little bit, because everyone in the ER's been through a lot through COVID, and they're jaded and busy. And, sometimes you have to advocate for yourself.
And we believe in that, don't we, Dave?
Yeah. Yeah.
Advocating for ourselves.
That's right.
And again, I'm just listening to this, and I am so overwhelmed because I had none of that.
Mm-hmm. Mm-hmm.
None of it.
Mm-hmm. Mm-hmm.
I was just concerned because I had just come home from Ann Arbor, had just had a surgical procedure, and I said, oh, I'm probably just nauseated because of the anesthesia, haven't eaten, been on the road, and, Derry and I don't necessarily get along. And I just said,
Mm-hmm.
But
yeah.
it's knowing
it could be pretty subtle. Yeah. I said it could be pretty subtle, the symptoms. And then the other thing that maybe would have happened, let's say you decided that day not to go in. Heart function is kind of down, and it's going to be down. People then will start feeling, maybe they would start backing up some water and get a little congestive heart failure, start getting some swelling, getting some shortness of breath, and then that would kind of bring them in. So we've seen that presentation too.
Okay.
All from the broken heart.
Mm-hmm. Mm-hmm. Because they have a lot of reasons to feel bad. Maybe they were at a funeral, or something happened, big surgery, don't feel good after, but then things aren't going the way you think they are, and you're kind of getting sicker, and then that'll be sometimes the clue.
Mm-hmm.
What did Dee say?
Dee said she has no family history of heart disease, and she turns 65 next May.
Mm-hmm. Yeah. So that person without any known things, I think if the question was, you wouldn't necessarily say take an aspirin every day.
Okay.
They just need the normal testing, cholesterol test, blood pressure check, height and weight, those kind of things. Yeah. And then we have actually a calculator that we use for, when you're seeing someone who has that question, am I okay? What do I do? And it put in your cholesterol and your blood pressure, your age, your other risk factors, and it will give you like a 10-year risk score. That's the one that's recommended now in the US. And if that risk score is high enough, then you'll say, oh, well, you probably should start on some medicine for your cholesterol, or your blood pressure should be at that lower goal that we shoot for now. That really helps kind of people kind of, know, or, it's pretty high actually. And we maybe ought to do some further testing, because that helps it. Because it's not just the cholesterol numbers anymore, like by themselves, because people often ask that too. My numbers are this. And you're like, well, if your numbers are that and you're 18, your risk lifelong may be high, but your risk over the short term is pretty low. So, you might tell that young person, let's work on your diet, let's work on your exercise, that kind of stuff. Versus someone who's older, you might say, yeah, it's reasonable at this point to start medicine and really work on that diet and exercise as well.
Mm-hmm.
What if you are not able to exercise like me?
Mm-hmm. Yeah, I always say you can do what you can do, right? You can, if you can do upper body, you can do pool work, you can do anything like that. Great, you can do it. But you're right, there are people, lots of our people have back problems, had multiple surgeries. They just can't do that part of it. So we just encourage, good diet.
Good diet.
Yeah, not the
Yeah.
American diet, not the fast food.
Exactly. Or all that, just always too much.
Yeah, portion size is a big deal.
Mm-hmm.
So
Too
we
much
can't
of a good
supersize it, can't get the biggie size.
Right.
We want to say hello to Sandra, who is watching. Thank you so much for tuning in. And you are rolling on the roll with Dr. Kimberly and Dave. Our guest today is Dr. Walchak. He is a cardiology specialist, and he is a member of the U of M Health West and Trinity Health Hospital cardiovascular team. We are just excited for all the information that we have received today. It's a little bit overwhelming.
It's a lot.
It's a lot of information, but hopefully you guys took away some great things about who needs to take an aspirin and when do you need to take an aspirin. And just to learn that 1% of the population can have it. How did someone even come up with that name?
Yeah, well, I think that the Japanese one was related to this gourd that they get octopus in. So actually, the shape of that looks like the broken heart on the echo. It looks like the same shape as that little thing. For us, the broken heart part is you just see the story. People will be at a funeral. People got some horrible news, saw something tragic, and then you find this afterwards. And so that kind of got that name. And that's a very dramatic name, and so it stuck. We call it apical ballooning syndrome now is the sort of more medical name for it. So.
And you know what that sounded like to me?
Broken heart syndrome is way more sexy, yeah.
Exactly. And
like
be
wood.
memorable.
Mm-hmm.
So how do you said only 1%, but what about during COVID when people were afraid to get it and to find out that, oh my gosh, you're positive for COVID and then you find out your whole family is positive, you're losing relatives, you're not being able to see them. Wouldn't a pandemic create an epidemic of the atypical ballooning?
Yeah, I mean, that's a great question. It's a great observation. I haven't seen any papers that people have noticed that. It's because it's so rare, but we know that we see with bad other viral pneumonias and things in the ICU, you can see it happen there. So it was probably happening. But people also weren't coming in. They weren't getting checked because, they're afraid to go to the hospital. Or they got so sick from, their COVID and things, you just didn't see that part of it because they just were focused mostly on breathing and oxygen and, trying to get them through that part. But I bet you're probably right. If I had to put money on it, there were an increase of it during then for sure, both because the social situations and it was just a bad infection. So that's a cost. Mm-hmm. Maybe we should write a paper. Maybe you and I, we'll go into it. We'll figure it out.
You know what? I think that we should. I like that kind of stuff,
Yeah.
I mean, even if we look at what comes to mind for me are all of the shootings that we've had at the schools.
Yeah, super tragic.
And to be in that situation, I would think that 1% would be higher than that.
Yeah, well, they have to come in. The 1% is 1% of people come in with chest pain, but they, but still they have to come in and be sort of seen, and you have to get that echo and find all that stuff. And so I think a lot of people probably get it, feel horrible, and then the body does repair itself after a couple of weeks, and they never knew they had it.
And then
it's only the people that. I'm sorry.
I said, and then it goes back to that question of, will you see that on a future echocardiogram that there had been some damage?
Yeah, not if it's not a lot. I mean, because the blood tests often with this don't go up quite as high as something like a heart attack where there's no blood flow and no oxygen to the muscle for a while.
Hmm.
So that's kind of one of the things you can't, diagnose it based on that, but you'll say, wow, this EKG looks abnormal. Well, the blood tests are just a little high, and then you kind of see the echo and you're like, okay, that makes sense. But it usually doesn't go up high enough that when they do recover, it looks pretty normal on the test afterwards. You can't see much for most people.
Oh, okay.
Yeah, Pat's betting that a lot of people have had it but didn't know it.
Yeah, it could be.
That again, you got something, but I'm over it. Good information, she says.
Mm-hmm. Mm-hmm.
There we go. It's almost scary to think, I can think of 5 people right now that I feel probably had broken heart syndrome when I saw how they received some news
Mm-hmm. Mm-hmm.
and then the decline in their health.
Yeah, I mean, a lot of things happen after that, right? You get the stress, the inflammation, and a lot of your body kicks in a lot of things to fight off, the danger, or the body doesn't know what's going on. It's just reacting to try to protect you, and can almost attack itself at times. And so you can see that a lot. I lost both my parents this year, and my dad, after my mom died, he definitely did that. He definitely declined, and his health just went very quickly down. And so we all have those stories. And so what is that mechanism? They don't really know that, but that there's some internal process that is just turning everything off, and it has to do with the shock and the grief, I think.
You said the one mysterious word, inflammation. Is that tied to the heart stuff? I mean, it seems like inflammation a few years ago, we never heard the word, and now it's like everything's inflammation.
Yeah, there's a lot of discussion and debate about that in cardiology in pretty much every facet. So if you take one of the big studies where if you took young people, Air Force, and you measured their cholesterol and a marker for inflammation, and you took the group that had crazy high cholesterols and low inflammation, and you took people with good cholesterols and high inflammation, their outcomes were the same. So inflammation definitely causes problems in the body and the heart. They think it's involved with the development of plaques and the progression of plaques, and probably has a part to do that the plaque gets inflamed, just like redness on your skin, and then the edge of it kind of weakens, and then it pops or ruptures. And then your body says, oh, I have a cut in my skin. Let's put a blood clot on that. And that's the mechanism for like the big heart attack. But the underlying thing that weakened the wall might be inflammation, they think.
What is inflammation?
It's your body's reaction. Yeah. So it's like immune reactions, white blood cells reaction. You have this whole other cascade of all these crazy chemicals and compounds, primarily really to fight off infection, right? So you get bacteria in your throat. This stuff kicks into gear, attacks the bacteria and kills it by all these different mechanisms. But other things trigger those responses. So living in high fat, high sugar world, cigarettes, stress, like the American lifestyle, all of that kicks that stuff to a higher level too. And so in your body, it's just floating around your body, just kind of causing havoc at a very, very low grade but chronic level. It's not good for us.
Okay, what does that say, Dave?
Tisha said that she has chest pains and sits down, breathes easy, thinking it's just gas, but never heard of broken heart syndrome.
Yeah, this is it's kind of rare, but it's a really interesting problem. But having chest pain and being evaluated for chest pain, that's a common day-to-day thing that all of us are doing constantly. So, I mean, if she's having it, it may just be gas. It could be high blood pressure. It could be a lot of things, but that definitely needs to be checked, right? Because your body's giving you some warning symptoms. Maybe, there is something going on, and it'd be important to catch it early before you actually get a full-blown problem. So I say anyone's having chest pains, they should be evaluated by their doctor for sure.
And D says,
I lost my lifetime best friend and biggest supporter last year, but God saw my hurt and gave me Dr. Kimberly. And I'm grateful that I have someone to share heartache and grief. she is a joy. That
Oh.
she is. And it looks,
She's unreal. She's amazing.
Who's
yes.
coming on there? Oh, Pastor
No, I
Peter's
can't.
it's trying to come on.
All right.
Just trying to get a connection, yeah.
We don't have a good, so we'll just kind of leave him right there. What are
'Cause
some of
that's-
the, go ahead.
I'm just gonna, and Dr. Kimberly's been sharing about herself, and I don't know how much she said on there over the past few weeks, but I got my worst case of poison ivy ever in my life. And so I get on prednisone, which is the standard thing, a little bit of steroids, and then my blood pressure's up. But
Mm-hmm.
the last time I had high blood or steroids, I don't remember what my blood pressure was, but I'm now a 60-year-old white guy. And so I got referred. Well, I mean, they made me see my PCP, my primary care physician. And then they said, well, we're going to send you to a cardiologist because, my blood pressure was still 150 over who knows what. And so I go see the cardiologist, and in one of my ER visits, they checked me for everything. I didn't have a heart attack because, again, my poison ivy it was just ugly. That being said, so I'm on my way for a stress test to make sure, the doc said, well, at least we'll get a good baseline. My cholesterol's usually been okay. My good stuff's low without getting too far into it. But all that being said, I'm feeling pretty good being well taken care of because, as I noted, I'm a 60-year-old white guy. But, this what kind of studies are people still doing? And are y'all getting any kind of training on disparities that, if the 55-year-old African-American woman comes to ER, it's like, you just had a bad dinner, as opposed to, I showed up and they did a couple of EKGs because my heart was feeling weird, but I'm on prednisone, I'm on a steroid, but they wanted to make sure. So how are y'all addressing that, if at all?
Yeah, that's a great question because I feel like everyone feels they don't do that or have any disparities or have any biases. That's the big one. A lot of people go in the profession are caring and giving and want to help people. But that, it's became to, I want to say, I don't think it was directly from George Floyd, but it was, the whole country kind of having that moment that became a requirement actually for the state of Michigan. Anyone that practices here, we have to undergo 8 hours of training in bias and education. Yeah, and you can get it through different societies and different companies provide that service now. And everyone was grumbling and complaining about it, but then they weren't afterwards most of the time because they have great data and evidence that this happens all the time, and that you need to be cognizant of it and aware of it and sort of overcome it. A lot of everyone I know are not bad people, but they all grew up where they grew up. I grew up in Brighton, predominantly a white town. Went to Michigan State, had white friends, you know what I mean? And so there are just things that you pick up and the things that you kind of are raised with and you don't even know they're there.
Right.
So I think it's pretty great that that's part of our training now. And I'm sure in medical schools it's more extensive than that, but they required at least for practicing people to get 8 hours of bias training now. And you have to redo it every license cycle every 3 years.
Okay.
So you feel that when you went to the emergency room the other day, as you send me this wonderful picture, I won't post it.
Thank you. Thank you.
In his gown.
He sends me this
So it's
picture
all-
of him in the emergency room, and I'm like, oh, okay. Are you saying that they gave you more testing rather than if it were me that came in, that I wouldn't get as much testing?
Potentially. I mean, I felt, I kept, and I mean, that's probably back to the issue about people going in after, 12 hours into symptoms. Cause I'm like, I'm okay. And my wife's like, no, we're going to the hospital,
Classic.
cause
the men always say they're okay. It'll go away. I'm fine.
So,
And then their wives drag them in by the hair and save their lives.
Yeah, so we're that piece of it. So I mean, I definitely felt that once I got drug in, I was taken care of well. But then that concern is, back to Letitia's comment, it's just like other people will say, "Oh, I've got these symptoms," and it's like, well, all right, we'll call your number when we have a room, as opposed to, again, as Dr. Walchak said earlier, that it's, if you're like, I think I'm having a heart attack, and you're getting rushed in, and they're
Mm-hmm.
doing all they can as quickly as they can, knowing that time is muscle.
Yeah, right.
I
And
want to
sometimes
welcome
it, like,
Pastor
our
Gaddy.
host would go ahead.
I want to welcome Pastor Gaddy real quick. How are you today, sir? Nope, we can't hear you.
Oh, he had said in the chat that
Oh,
his connection is bad because
ca-
he's traveling.
yeah. Can you hear me now?
Yes.
There we go. Yeah.
Awesome. I was just saying hello to Dr. Walchak, Dr. Day Bukowski, and Dr. Barrington. Coming in, running off the road, trying to get a good internet connection. But I am in the room now. How are you all doing?
You're
Good.
doing good. We're
Very
talking about some of the now we've moved into some of the disparities that may happen because the type of heart attack that I had is not, it's what 1% of the population may have it.
Mhm.
And I want to say on behalf of U of M, and I don't get a check from them, trust me. I, with all seriousness, I do not. But having been it's been almost 10 years now of being in the wheelchair. I've been African American all my life, and I've been a female all my life. I have to say, I have been treated with the most utmost respect by U of M, and I've had quite a few visits this year with myself as well as my husband. And the VA has now partnered with U of M, so that when we have an issue, like I did when I called in, I say, "Hey, I'm not feeling too great." They said, "Hold on, you know what? You need to go over to the hospital. Where do you want to go?" I said, "U of M." They said, "No problem." And I love it. You guys have record sharing, so they're getting it in real time. Medications, if you put in an order saying, "Hey, you're going to need to take this medication," the VA fills it. And, all my medication was waiting for me when I got out of the hospital. But I have to say, Dave, when I came in and I wasn't presenting as a normal person having a heart attack, and the only symptoms that I had was the nausea, and I said, "Hey, I've been vomiting, a few times. I just came in from Ann Arbor just a few hours ago, had another procedure," and they were on it. I have to say, even though when I came in by ambulance, it was a little crazy because there wasn't any, number one, there wasn't any room when I got there. And so they had to take me off the gurney and put me in my wheelchair and bring me in through the regular emergency channels. And what I love is that the not the ER workers, but the EMTs stayed with me and they checked me in. Now, I'm not going to say
That's
that
great.
the emergency room staff there was very nice. There was a couple people that I had to redirect. I'll just say it that way. There was just
Uh-oh.
that much redirection,
Mhm.
and everybody's immediately said, "Oh, that's Dr. Kimberly. Uh, we better get this thing together. We know who she is." And then they thought it was a stroke, is what they just made the assumption, because
Mhm.
I already had deficits from having a stroke. So they said, "Well, maybe she's just having another one." Nobody ever thought that it was a heart attack, nor did I.
Mhm.
But they got me in the back. They had me in a private room, and everybody was pulling everything together. And as soon as they hooked me up for the EKG, and they're like, "Are you sure that this is just from vomiting? And that's why you're here?" And I said, "Yes." And I said, "What's going on?" And I heard them announce, do the big announcement. And I hear people scuffling around. And I said, well, I started praying. I said, well, Lord, I said, whoever's having a heart attack, don't let it be unto death. I hope that they're okay. Because I'm just here because I was vomiting. And it was me. And they're all running in the room. And I honestly have to say that the staff was just excellent in how they moved. They got things together. And as much as they were baffled by that, it was the only symptoms that were presented was the nausea. And I had, a headache, and I just assumed that the headache was from not eating. They took it very seriously.
Yeah. Well, that's really good to hear. That's actually really good to hear, because that's what, the system tries to do. But I think, to Dave's point, and there's definitely data to show that those other things you were hinting at or concerned about, that happens. I mean, that's what now people realize. They've done the research, and that's why the education is happening, to try to limit that from happening. But we've had it too, where we look at every case and every heart attack and stent we put in. We're in, actually, U of M has a Blue Cross Blue Shield partnership, where all of the hospitals in the state contribute data, and we all get together and look at it. We do projects every year for quality improvement. And so we look at all those at our facility, and then we're like, well, why did this person take, an hour and 20 minutes to get their artery open with their heart attack when we're supposed to do it under 90? And most of the time we get it closer to 60 to 70. And then we look back, and sometimes it is like they just had, they described left wrist pain. And it's really, when you talk to them more, it's more their whole arm, like radiating pain down their arm. But the way they expressed it was like left wrist pain. And so they just thought they had a, bruised wrist or a sprained wrist. And so they do get placed in a different area. They're triaging those people. So occasionally that does happen, just based on the story too. The nurses taking the intake doesn't ring a bell for them that it could be a disaster,
So then I don't think that it's fair to say that, there's racial bias if I don't know how to present, what's happening to me. And if that's all that's bothering me, I did my job and you did your job. And so I think that we're doing well. But what I do want to say to Pastor Daryl, because you pastor in the inner city, what are some of the things that we can say to him where, in a Bible study or having a conversation, to say, this is how we better equip ourselves when we go to the doctor and how we get to the emergency room? What do you think about that, Pastor Daryl?
Yeah, I do believe that being able to articulate symptoms, being able to understand your body, being able to communicate well when a person arrives at an ER facility or are being treated, I believe that's important. But I do believe that the empathy aspect of it is important as well, recognizing that we treat people the way we want to be treated, in spite of how they are able to communicate or articulate a specific feeling or something that's going on. It comes back, I think, to a general understanding that we know that we're dealing with individuals that are not medical professionals, yet they have the need of the expertise of those who are now being responsible to serve them in a medical capacity. So I think that it's on both sides of the equation, that the patient has to be able to understand that they're trying to be understood. And then I believe that the person who's doing the treatment or the intake has an equal responsibility of just being patient and understanding as we try to glean from them what is going on. But the general rule of treating people as you want to be treated, I think, operates on both sides of the equation. And I believe if we start there, that we'll be able to get to the end of the road, which is diagnosis and treatment, so that we can try to maintain the health of the individual. When you talk to in terms of being a pastor, I do work very hard at teaching the congregation and our community members what it means to engage professionals in any aspect, and to be able to be as respectful and as responsible as stakeholders and as citizens of our communities as well.
Yeah. And it's interesting that you kind of say that, because there's a great kind of understanding and like a little bit of a movement of trying to get healthcare to people in their community and in the places where they can receive it well and receive it in churches is a big move. And barbershops is a big move. They did a great high blood pressure study in barbershops in California, and had a great response of lowering blood pressure by trusted people that they see every month, sometimes a couple times a month, and versus a doctor you might see once every 3 months. They got some pharmacists and nurses in there, and so there's a great understanding of people want care where they live and where they go to church and where they do their social activities. Versus, let's say, New York City, you have to travel for 45 minutes to an hour and a half on trains, and to get to the big hospital, they want to have that care where they're at, and they're more receptive and kind of more open to it there too, I think.
Well, we have Cherry Street Health Center and we have Grahi. What other piece do you think that we need to put in there within the Black and Brown communities? And we have the Hispanic Center, and in order to kind of bridge that gap. Anybody?
I think we need some clinics right southwest of downtown, because part of one of the talks I did for the stroke conference was disparities in hypertension. And if you Google map and look at some of the information you can get from the census, where people live, I mean, there are no clinics right there. There's no grocery stores right there. Everything, if you don't have an automobile, you have to take a lot of bus trips to get to anything that you want to get to. And so, I mean, that's a clear kind of area of just disparity of access that I think is there. I've been kind of wanting to do that for a while. I don't have that money myself. So I'm trying to talk to the hospital about, you need a clinic that you can put right down there that people can walk to. And that would really help, I think, especially my thing, hypertension.
And where?
Kind of south on Division, between Division and 131, kind of southwest of the right downtown area. You know what I mean? Kind of, oh boy, what's the side street there?
Well, not to push off or put a spotlight on a different faith community, but like where New Hope Baptist Church is, which is on Delaware, just south of Martin Luther King Street. So Delaware and Division. Mm-hmm. There's the Grand Rapids Housing Commission has a community space, because then they have a development. There's a retirement community there, and then New Hope Baptist is to the west of that.
Well, there's that parking lot. Well, it was not a parking lot anymore. It was a building that did restorations for fires. That space is open. That would probably be a really great space to put a clinic there. And then you have a great.
Right. I mean, it's a good idea, right?
Yeah.
But where are they all being built, right? They're all being built around the city, in the outskirts, right? Ada, Cascade, well, that's where all the hospitals. They're trying to reach out to the countryside. I get that, but
the rule.
We once mapped all the specialists in Kent County, and it's like most of the specialists are in the townships for their offices, and that bus service doesn't go out to most of the townships. And so that just mobility as a massive barrier. So yeah. And then of course, I have said this one of my things I like to whine about, Dr. Kimberly, is that, they'll say, why go to the ER? Why don't you go to a med station? Well, if you map med stations, all of the med stations except the one on Alpine Northwest are all outside of the bus zone. And
there's one on 44th Street, almost to Division.
All right, so we got two
right
now.
The bus comes right in front of it.
There, you should have a med station right next to the ER. I'm just saying,
Yeah, some hospitals have that where they'll kind of triage, because some people will come because they, have a very bad cold and they don't have a primary care doctor. Those people will be perfect to shunt over to the med station. And the ones that do show up at a med station with a heart attack, they are great about saying they get EKG right away, and they're calling ambulance and they ship them right, out of there. So it delays it a little bit in terms of their care and the time that we try to get them in and get them treated. But, that is just a health education part of, what do I do? Where do I go? Have a family doctor or not? Do I call them? So this is just part of, the problems that we deal with.
So we just health awareness. Reiterate, since you said that, we want to reiterate that you said within 12 to 24 hours preferably within 12 hours of having heart attack symptoms, that you
Mhm.
need to get in and be seen.
Yeah, faster the better. Yep.
Yeah.
Dr.
Pastor,
Kim, there
yes,
is
sir.
a piece of this one. While pastoring in Detroit for 13 years, we did a partnership, our church, with Macaulay Health Services, Walgreens Pharmacy, and University of Detroit. And we did a 10-week hypertension awareness training for members of the community at the church so that they could identify and be able to know the signs of hypertension, how to some of the eating and the diet and just various things they were trained in partnership with a health community and an educational medical educational facility, but that also gave us kind of a partnership and an inroad to some of our medical providers. And I think it would be a great opportunity to really think about what it would mean for the faith-based community, the nonprofit community, development community, with our medical community to come together and think about partnering in a medical facility on that side of town. I think it would be a great inroad to not only education and training, but also identification and treatment of symptoms so that we are connecting community to being healthier while at the same time treating folk who have pre-existing conditions in the hypertension area.
There'd be, yes. I'm getting a big smile on my face. That, you could have educators, people that could just be lay people that are health educated. You can have social workers. You can have, all the people that people need a variety of facets of things for. Sounds
Absolutely.
fantastic.
Are we all getting excited? See, Dave, this is what happens. Here when you're rolling, we roll around to conspire.
For good things.
Exactly.
We absolutely do. Because I could see that we could, do a live in that area, and you could just say, we're looking for some donors. Who wants to really help us get this space? We can put a lot behind that and make it happen, because
Yeah,
it
I do
definitely
believe. Yes.
Well, and the idea I just had earlier today, I got the email notice that my blood pressure cuff is been shipped because, as I mentioned, now my blood pressure is up. So I got to check my blood pressure every so often. And it's like, how come we don't just give those away like hotcakes?
That's a
While
great
Dr.
question.
Kimberly's raising the money for that new clinic, I'm all in favor of that. But even when the new clinic is there, it's just like, hey, did you check your blood pressure today? Hey, let me quick check. I mean, it's just like,
Yeah.
it's
Well,
got to be a big special thing.
I
Like,
think that would be a really great show, that we find the folks that are doing especially the VA has this contract that if you have high blood pressure, you immediately get a blood pressure cuff. And then what they make you do, you get this telehealth system. It is nice. It looks like the old phone systems that we used to have with the I'm sorry, I'm laughing because just to even think about it, with the old answer machine attached to it. You remember how big those were? Well, you get that, and every day you they program when you need to check in, and you come in, and it has a blood pressure cuff attached to it. It reads it, it sends it down there, and then they give you this little spill about, well, hello, thank you for checking your blood pressure. This is what your blood pressure was today, and these are some of the things that you can do in order to lower it. And then if you go in like for a few days and it says that it's gotten lower and it's nice, she comes on and she says, you have done a really good job following all of the steps. And once you get down to an acceptable range, then it says you have completed the program and we ask that you continue. But it goes through step by step of identifying high blood pressure. How are you going to feel? What you need to do? What are some of the things that you can do if you feel like eating? If you stress eat, then we suggest that you go for a walk. I mean, it goes through the whole thing.
Yeah,
And
that's great.
and the V gives this to us folks. And I'm thinking, how much money would the insurance company save if they did more preventative care? Then it's
Exactly.
always reactive care.
The whole system is kind of built around that, unfortunately. Yeah, they know it, but you still have to go buy the cuff, right? And I think the last time someone tried to get one was $80.
Really?
That's a lot of money. So we actually, for our hypertension clinic, were able to get some funds from they were at that point Metro Health Foundation. They gave us some funds to buy cuffs for people in need that come in. They're having trouble with their blood pressure. They can't afford it. We could give them a cuff, like you're saying. But it's probably the most important part of the annual checkup because you don't feel it when it's high typically. It's the silent killer, and you won't know until something happens if you're not really good about checking yourself or getting checkups. And certainly, you can be checking yourself and your family at home. It makes me crazy as well. It's such a manageable thing with diet and exercise and weight loss. And if not, we have 200 generic pills that are cheap that can manage it. And it just is getting to the point of saying these are the numbers. This is I need to get it managed.
But why can't we go to Big Pharma and say, hey, would you like to donate, 1,000 blood pressure cuffs? I mean, they all came together when we were looking for solutions for COVID. We were trying to get PPE packs together. Beer companies gave alcohol so that they could start making, sanitizer. I mean, we can tap into our friends. I mean, we have, and I'm just going to say it, because I can. We have all of these cannabis growers and these clinics. They're giving away free weed. There's a sign right here as you get off of the 131 at the 68th Street exit. Hey, get some free cannabis from us. It's like, how about you go give me a blood pressure cuff? I don't need no weed. I need a blood pressure cuff. My baby needs some Pampers, a couple of pair of shoes. It's school time.
Right.
But seriously, I was told that if they open it up, that they're supposed to give something back to the community. I'm not sure what the percentage is, but what would it look like if Dr. Kimberly made a phone call this week and said, hey, I see that you made $100,000 last year selling weed. and the same friends that you sold this to, they need blood pressure cuffs. How about we
That's a great
partner
idea.
together? And for every ounce that they're buying, they need to give them a blood pressure cuff.
It's great marketing for them. They would
And in our partner,
100% do it.
Yeah. In our partnership with Walgreens, they provided them for all of the participants in our program. So I believe that we have some businesses within the community that are already partnering that we just need to tap into. They're already there. And so I'm ready to charge ahead. I'm a dreamer, Dr. Dave and Dr. Walchak. I'm one of those guys that I like to put the boots on the ground and get it done. So I think this is a great conversation, and I think it's something that we can sink our teeth into and make happen. I really do. I like the way it's moving.
This is fantastic.
Look at you.
We're just talking about broken heart syndrome, and now look at all this blood pressure stuff we're doing. This is exciting.
You never know. You never know when you want to check.
But you know what? We talked about this before everybody came on, Dr. Eric, that this is where I really wanted it to go. Did I not say that?
You kind of hinted that, yeah.
And sometimes she gets what she wants. And so I think that we need to make this happen because I really see the importance of it, having experienced it firsthand. You need to have it. And yes, do I have all of the great insurance and the supports from the VA? I do. And that's the other piece is that if you're a veteran, if you served, 90 days, you're entitled to medical. You're entitled to medical. So
it happens that they don't know that sometimes. Because they'll be on working somewhere with whatever insurance and it doesn't cover what they want or something. And I'm like, you get it through the VA though, right? And they're like, I don't think so. I'm like, I think you need to call them. And also often the spouse can have benefits too, that they don't know that.
Yeah, if the veteran is 100% service connected. So if you're out there listening, if you are a veteran that's 100% service connected, your spouse is, first of all, you're eligible to put your spouse on your case as a dependent. And then number two, they are eligible for health care through the VA.
And shameless plug, wherever you're listening, don't hesitate to call your Center for Independent Living. ILRU.org is the national directory, because we navigate folks to community resources. You're not a veteran, you're not employed, but yada yada. We got to find something. Worst thing we can do is tell you there's nothing out there, but give us a shout. We'll try to find that resource, because no need to suffer in silence.
Absolutely not. And you all know how to find me because you find me. you find me on all 7 platforms. And most people say, well, I Googled you. Yes, because Dave, you know how I feel about Google.
The Google.
Yeah, the Google. And now we have a new community partner. We have, drum roll please, we have Pastor G.
Indeed. Well,
I think he's stuck.
Uh-oh.
Here we go. Tap, 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 tap.
But we're at that time.
I think we've gone past that time. What time?
We have. So my last thing is, Dr. Walchak, hopefully I see you before the ribbon cutting at the new clinic.
Yeah, it sounds good.
So thanks for saving Dr. Kimberly, and thanks for all your awesome work in the community.
Thank you so much for having me, guys. This was super fun.
It was. He says that he can come back again. So
for sure.
We're going to have to put him on the schedule. But actually, we need to set up where we have meetings. I think Pastor G is now moving again. Could you hear us?
I hear you.
Any final word? What we said, we don't know if you heard what we said, that we have this great consortium here, and we're excited. I said, drum roll, please, to have Pastor G on board.
I am on board. I'm grateful for now being a year in Grand Rapids, working in this community, and having brain ability for the people, whether that is spiritually, whether that is economically or medically. We want to be able to support the community and bring the collaboration of partners together so that we can get it done together. So I think, God allowed me to be on even late today, but I look forward to what's going to happen as we charge ahead into the future together. So that's my spiel.
Okay. Well, you have been rolling on the road with Dr. Kimberly and Dave. This was an awesome show. It's just the beginning of the conversation. We all will be coming back. We thank you for all your comments, all of your love. And this show will air again on GRTV in about a week. Yeah, they have a few more of our shows. And we are on 3 times a week on GRTV, Public Access Channel 25. So we're excited about that. And you can always see the replay on YouTube at 100 Shades of Diversability. We are so grateful for you, Dr. Walchak. Oh, my goodness. Not just coming on the show, but me personally. Yes.
Well, I'm grateful to meet everyone else, and I'm grateful you guys let me kind of run on about medical stuff. And thanks for being an inspiration, Doctor.
Oh, I don't know what else to do, huh, Dave?
That's it.
We don't know what else to do. So again, this is Dr. Walchak, who is a cardiology specialist with U of M Health West and with Trinity Health. And we are so thankful to them and to Chris, who set this up and made it possible. So I'm going to jump on the horn. Chris, we need him back again. So we appreciate that. And we are so grateful to Pastor G for catching up with us while he's on the road. We had something really special for you. So we want you to hear what we had, and we're going to play it because you missed it.
Hey, come on, everybody, it's time.
Oh, I got it. Let's do it. Yeah.
Rolling on the road
With the doc,
rolling on the road,
with Dave,
rolling on the road.
with the doc.
100 shades of diversibility with guest host Pastor Darcy.
no, he's stuck again.
We'll get him when he's in GR and good
Play it
internet.
for him.
Absolutely. Thank you, everybody, for tuning in. And thank you again, Dr. Walchak, for coming on. And we will see you soon.
Bye-bye.
Did you hear it, Pastor G?